So this portion of the agenda, myself and Bob Cawley will be up momentarily. We'd like to speak to the terms of participation and some information on funds flow. In fact, earlier today, I mentioned that the performance payment methodology had been finalized, and there were some details that we needed to have to really consider that methodology was in final form. And that, what I was referring to was the state's methodology for evaluating performance of the PPS as a whole in disseminating funds to the PPS. So in a minute, I'll show you how we call that filling. Filling the bucket is final, emptying the bucket is not, and we'll talk about that momentarily. So first, let's look at the terms of participation. So this morning, Kathy described the PPS governing structure, including the responsibilities of AHI and the various subcommittees. This slide shows the responsibilities of the PPS participating organizations. So it's also known as the terms of participation that form, together with some other elements, the participation agreement. So each participant is responsible for participating in such projects as mutually agreed upon, collaborating in good faith, implementing clinical protocols that have been determined for the selected projects, reporting financial and clinical data to the extent necessary for AHI to meet its reporting obligations to DOH. That's an important item. You know, one of the responsibilities of the PPS is to monitor the financial health of the PPS as a whole and to look at some indicators of financial health across the network. We're required to do that. In order to achieve the milestones, we also need to do other types of assessments other than that financial health assessment. We did some initial assessments of technology readiness and capabilities. A more detailed assessment will be forthcoming in that arena. So it's really the part of the terms of participation that the participating organization is agreeing to meet those reporting, to provide data to meet reporting requirements, and to cooperate with the development of the implementation plan, which includes the surveys necessary to determine the next steps. These types of responsibilities are things that will be incorporated into the methodology for the initial disbursement of funds from the PPS. So at this point in time, I think most people are aware that DOH did make an initial disbursement of funds to PPSs. That first disbursement was, a few months ago now. It was June. So a check came, interestingly, on paper with the little perforated thing. A big check came, and and that check is sitting there unused because we had to have the governance and the methodology. You had to have the governance in place to to authorize disbursement of those funds. So any of AHI's costs to date have been funded by planning dollars, which was a separate pool. The first disbursement came to the PPS. There it is. To our knowledge, there is one PPS out of 25 that has made disbursements from their initial distribution. I bring that up in part to really kind of level set our expectations when it comes to the pace about the development of the financial methodology. You'll hear a little bit about it momentarily, but it's no small thing that New York State has put in front of PPSs to really design that methodology with few parameters. I won't go into the I won't go into, the details of those parameters, but there are a few. Things like 95% of the disbursements must go to safety net organizations. Subsequent to that disbursement, the safety net organization then has a great deal of latitude as to what are appropriate uses of those funds. But one PPS out of the 25. We asked some questions. We tried to find out more about their methodology. What we know is that at this point in time, there's not a lot to go on other than this early in the game, other than attribution. And the state did indicate from the very beginning of DSRIP, and they continue to reinforce that a methodology based primarily on attribution is not in line with the state's expectations or intentions with the funding. That being said, attribution is important. It's just not the only element. There are other really very much needing to ensure that the monies that are dispersed out also are done so on a performance basis. So I'll talk a little more about those in a few minutes. But so types of things that you see in the terms of participation, including participation in the various meetings, assessments, and other requirements. Reporting is a requirement. So in addition to the items on the previous slide, the participation agreement will also address these topics. So there is a clause that describes the method for dispute resolution, termination, remedying for underperformance, confidentiality, and so on. So that, as we mentioned this morning, that contract, the participation agreement, is drafted. It's in its final bits of readiness to get sent out. You will get it very soon. So think of the terms of participation as the global agreement that outlines the parameters, the rights, responsibilities of both AHI and the partner organizations. So that master agreement is one that all of the partners in the PPS would be identical. Everybody would have the same terms of participation. AHI's rights and responsibilities, of course, would be the same. So in addition to the terms of participation, there will be scope of work attachments that are specific to the projects that the provider is taking part in. So again, part of our reason for wanting to secure up those provider commitments so that we know best what type of agreement we need to put in front of each organization. Now, the scopes of work, there won't be a canned scope of work for a project such as 3GI that's identical for every single organization taking part in 3GI. Why? Your role and responsibility may vary depending on your provider type. If you're a patient-centered medical home, I realize not everybody knows what 3GI is off the top of their head. Palliative care into the patient-centered medical home model. If you're a patient-centered medical home, your scope of work for 3GI is going to look different than if you're a hospice provider, than if you're a community-based organization that is educating communities about hospice and palliative. So there are going to be different duties depending on your provider type. Okay, so that's what we're looking at in terms of structure. So the funds flow, the piece I talked about this morning that has been finalized, these things called achievement values, this big pool of ones and zeros, the manner in which they're aggregated and weighted has been finalized. Those ones and zeros are things that are earned if you achieve a milestone or you achieve a clinical target. So the ones and zeros are, in fact, the dollars that fill the bucket. So the bucket is the PPS's net set of disbursements. And you may wonder, well, how did we already get a disbursement then? What have we achieved? If you were to ask our state Medicaid director, Jason Helgerson would say that that every single DSRIP dollar is a performance-based dollar. And what he means by that is there was a prescribed set of achievements that the PPS had to accomplish to get even that first disbursement. So that included items like the successful completion of an implementation plan that had been signed off by the public approval and oversight panel. So it was that panel's process that finalized and authorized the state to go ahead and make that disbursement. There are, of course, a whole range of achievement values that remain to be earned every quarter that continue to drive, that will continue to drive payment. And as I said, the PPS, each PPS has a fair amount of discretion in determining how to empty the bucket. So the emptying of the bucket process is the one that is in development. We're together with our other 25 PPSs, have been working hard to determine the parameters that need to go into that aspect of the funds flow. At a high level, the elements that will be tied to disbursements would include elements such as level of engagement, progress in accordance with commitments that have been made, performance to the extent that it can be measured at the partner level, and of course attribution or reach into that target population. When I mention performance and I say that could be taken into account to the extent it can be measured at the partner level, that filling of the bucket requires the PPS as a network to hit clinical targets. We can't just cookie cutter that methodology that fills the bucket and use it as the one to empty for a variety of reasons. And one of the reasons is those clinical measures. There simply wouldn't be a large enough N, a large enough sample size to say that we had a target as a network, we're going to in turn use that, set a target for you and be able to adequately measure that and drive and connect your funds to it. In many cases, there just would not be enough individuals for that to be a logical approach. So performance certainly is important on clinical measures as well as overall project performance, meeting the milestones on those projects. So we have an example that Bob is going to share with you.
Thank you, Colleen. I'm Bob, and I'm an acronymophile. So if I do start falling into acronyms, and believe me, this healthcare reform space is a really bad place to be for somebody like me. Stop me. I'll do my best to explain what they are. So a couple things up front before we get into this is what we're laying out here is kind of a straw man. This is by no means a final product. It's an idea of the concepts behind how we see the funds flow playing out for the projects and for our partners. Just trying to provide a framework for you. We're looking for feedback from you on this. And I would also say that for this part of the presentation, we have anticipated a lot of questions, so we left some time for questions for you. So please don't be shy about grabbing a mic and asking some questions about this. So if we look at Project 2A, which is, this is creaky up here, which is achieving NCQA Level 3 Patient-Centered Medical Home by March 31st of 2018. And technically, there's more to it than that. There's meaningful use and other things, but this is the core of it. And so what we're trying to do is find ways to tie your progress in achieving medical home to the disbursement of the funds, trying to empty that bucket, right? So what we're looking at is combinations of the DSRIP milestones, and now the NCQA factors and standards and elements that make up the recognition. And this should be consistent with what you see in the PA and what you see, what you see in the participation agreement and what you see in the statements of work for this project. As I said, what we have up here is an idea of how it might work. This is not a final project, so don't go back and tell everybody, well, this is exactly what we're getting paid on. This is an idea. First thing is the assessment. As Ruth Ann mentioned earlier, we're going to be engaging each of the practices in an assessment of their NCQA readiness. And we have a very, very wide range within the practices in the PPS. But this is going to go a long way to determining exactly what the funds flow for any particular practice is. But since it's also such a critical element, one of the thoughts we have is this also should be tied to some funds flow right there. Same thing with getting a physician champion within each practice, somebody who's committed to that practice in a leadership position, achieving medical home, because our experience, and I think the experience broadly with medical home, is if you don't have that buy-in at the top of the practice, it's not going to happen. So again, thought process is it might be a good opportunity to tie some incentive to that. Then we looked at some of the PCMH factors, and for the most part, these are must-pass elements to get to level 3 2014. So if you don't have these, you're not going to make it at the end of the day. One of the things that we're going to need to be able to figure out is how to document this effectively so that we can collect the same information from every practice to be able to determine that they are on the road and successfully moving towards achieving NCQA recognition. So what we are doing with this project is we've actually, Ruth Ann is going to be assisting practices, and we're looking for other resources to do this as well. They'll be certified by NCQA as in training practices to get to medical home recognition. But as I said, we've got really a wide range of capabilities and resources within the PPS. And thanks in large part to people like Karen Ashline and Cindy Reynolds, who have led transformation in the medical home, we've got some people that know a great deal about medical home. At the same time, we have people who still, if you said PCMH to them, they may not even know what that is. And so I think of this kind of as 1A and 1B, or 1A, 1B, 2A, 2B, where AHI will provide resources, and that could either be our employed transformation coaches, or it could be an organization that we contract with to fill that capacity. For some partners, they may have that capability in-house to achieve NCQA recognition on their own, and that's an option as well. Some of our partners may want to contract with another vendor to provide that service. All of those options are on the table, so our challenge is going to be to make sure that no matter what option is taken, that the requirements and documentation are the same across the board. Okay? So, as far as the support for these services, again, the thought is that we're going to be distributing funds based on achievement of these particular milestones. But we have some practices that are already NCQA 2011 level 3. We have some practices that are very close to getting recognized for NCQA 2014. So part of the difficulty here is going to be for a practice that is already along the way, how do we provide some recognition of that, but make sure that we're using our resources to really get practices that need the most help to NCQA level 3 2014. So that level of support is going to depend a great deal upon the assessment that we do when we start off. It may or may not cover the full cost of the resource. And this is where while this example may not apply to every project, one of the concepts in here that's key and across the board is the idea that DSRIP is a Medicaid program, but in a case like this, and in most cases really, it's really transformation of the full delivery system. So in the case for a practice, you don't become NCQA recognized for your Medicaid patients. You become NCQA recognized for all of your patients. So part of the consequence of that, though, is that it also opens up opportunities to save expenses, cut costs, or to bring in additional revenue to the practice. So there is some responsibility for the practices to take on some of this cost themselves as well. As I said, DSRIP is not going to be paying for this whole thing. It sounds like a lot of money. I mean, $6-point-something billion statewide. But when you start, you don't have to dig too deep to start realizing that you could spend that money many times over in trying to achieve what we're trying to achieve here. So we are going to need to look at other resources. DSRIP is part of it. The CRFP process that was referenced earlier is part of it. As I just mentioned, partner resources are going to be part of it as well. But we're also going to be looking for other public and private sources. Federal, here's my acronyms. Most of those, I think most of the people here should know. State, SIM is State Innovation Model. That's the testing grant that Colleen referred to earlier. PTN is another one, yes. So and what I was going to mention is within the state, within the SIM, which is a grant that's really a companion to DSRIP within the SHIP, State Health Innovation Plan. The SIM has a couple components to it. One of it is going to be health information technology. So they're planning to create an all-payer claims database. They're planning on building out the SHINY, the State Health Information Network New York, which is a collection of all the regional health information organizations in the state. And they're also looking to leverage regulation and policy from Department of Financial Services, Department of Insurance, Department of Health, OASIS, OMH, all to try and help facilitate this transformation of the network, of the system. But a large part of the SIM is what is called APC, or Advanced Primary Care, which is very similar to NCQA Medical Home. In fact, we consider, and Foster Geston, who leads the Medical Home program, said this again yesterday in our governance committee meeting, that NCQA is a necessary but not sufficient component of this transformation. The idea is that this advanced primary care will get us to that sufficient level to achieve this. So our program is going to help practices prepare to be APC, and in some cases really help them get to be APCs. And that is going to allow them an opportunity to receive enhanced payment from the commercial payers as well. So there's one of those opportunities for increased revenue. Along with that, as Colleen mentioned, is so that APC, about $60 million, if I'm correct, is transformation coach resources that the state is going to provide. There's also a practice transformation network that was just awarded a few weeks ago, and I believe that's $48 million or so. And it's a similar thing. It's transformation coach resources to help practices transform. One of the challenges for us is that since the medical home has been at the forefront, they are saying that we really want to allocate these resources to the practices that need it the most. So PTN explicitly excludes MAPCP and ACO practices. And the state has also said that they're going to prioritize practices that have already been involved in CPCI, Comprehensive Primary Care Initiative, ACO or MAPCP, Multi-Payer Advanced Primary Care Practice, lower than the practices that have not had that exposure. So in a lot of ways, the DSRIP funds that we have are the only opportunity for some of our practices to get support for this. But again, trying to leverage all these different sources to fill in the gaps, and that's a huge part, actually, of what AHI provides, is trying to bring all these different programs together in a comprehensive and coherent fashion. So, as I said, DSRIP is not going to fully fund this. We all have to use the resources at our disposal to do this. And we keep referring to AHI as the PPS. Well, AHI is really the PPS lead. All of you, all of us together are the PPS. So it's going to take a commitment from all of us to achieve all of these projects, not just 2A2, but all of them. And so I just kind of wanted to close with that to kind of correct that little piece of language that we've been using. When everybody here is the PPS. It's not just AHI. So.